Good afternoon, ladies and gentlemen. Dear Mr. Chairman, thank you for your kind introduction. And it is my great pleasure to be here in Chennai again after 3 years to speak about glycemic variability, history or future. In the beginning, I would like to take opportunity to express my gratitude to Dr. Sadikot and Dr. Banshi Sabu for inviting me here, as well to the organizing committee. The road can be straight, winding, or bumpy. Now I will take opportunity to show you the beautiful landscape of Golden Gate. If you imagine that on x-axis will be time over the day and on y-axis will be glucose, this would be the typical measurements of glucose during the day. But however, we might not have the whole picture if we just choose these 4 measurements per day. Fasting plasma glucose is important. Postprandial plasma glucose is even more important maybe. But HbA₁c. But what about glycemic variability or maybe another measures of glycemic control? Today we will speak about the role of glycemic variation. Last year, JAMA published on the front page glucose excursion picture to emphasize the importance of glycemic variability. HbA₁c is the common measure of glycemic control, and it includes normal glycemia, fasting hyperglycemia, postprandial hyperglycemia, but also it includes also hypoglycemia as well. There is no doubt, there is many evidence which will confirm there is a strong association between hyperglycemia and diabetic complications. Also, there are lots of evidence which will confirm association between postprandial hyperglycemia with the risk of cardiovascular disease and mortality. However, you are all aware of several recently published trials which cannot confirm that intensive glucose control is beneficial to prevention of diabetic complications. There is no significant effect on macrovascular complications in advanced or VITD study, but also the Accord study showed the increased mortality in group of patients with intensive care comparison to standard diabetes therapy. Different measures provide different insights. We are always, when we are talking about glycemic control, we are talking about HbA₁c and we are talking about glucose, fasting plasma glucose and also postprandial plasma glucose. But also postprandial plasma glucose or postprandial excursions means there are different consequence of postprandial excursions: glucose toxicity, prolonged hyperglycemia, and also acute hyperglycemic effects. When we are talking about acute hyperglycemia will cause glomerular hyperfiltration, will increase retinal perfusion, and also will cause peripheral neuropathy and autonomic effects. On the other hand, it will increase cardiovascular and cerebrovascular risk. Prolonged hyperglycemia will cause protein glycation, hyperinsulinemia, but also long-term complications. The possible mechanisms by which hyperglycemia can increase cardiovascular risk are listed here: endothelial dysfunction, dyslipidemia, increased thrombogenesis, and also increased adhesion molecules. But also, hyperglycemia will contribute to macrovascular disease, but by many different mechanisms. By increased protein glycation, increased endothelial damage, increased sorbitol formation, increased postprandial hyperlipidemia, activation of protein kinase C. But it seems that oxidative stress is the cornerstone in pathogenesis of chronic complications of diabetes. Our patients are in postprandial or post-absorptive period during the whole day, except early in the morning before breakfast for 2 or 3 hours, but some of them even not during the, because they have some short snack even during the night. There is no doubt that postprandial glycemia has major impact on 24 hours glucose profile, and also that postprandial glycemia or postprandial hyperglycemia is the first recognized alteration in type 2 diabetes patients. HbA₁c reflects both fasting and postprandial hyperglycemia and includes normal glycemic periods and also hypoglycemic periods. For optimum management of diabetes, we should target fasting plasma glucose, postprandial plasma glucose, but also HbA₁c, but who knows, maybe even glucose variability as well. HbA₁c is a gold standard for estimation of glycemic control. On the other hand, it's the gold standard for estimation the risk of diabetic complications. It's a gold standard for guiding treatment algorithm, but also it's a new diagnostic criteria for prediabetes and for diabetes as well. Postprandial hyperglycemia, it's not glycemic variability. Glycemic variability will include also hypoglycemic events, postprandial glucose excursions, but also minor fluctuation of plasma glucose. Glucose variability will include, or also is called, glucose swings. Patients can have same mean blood glucose value, but different fasting plasma glucose, different postprandial glucose, and also different glucose swings. On the other hand, they can have the same fasting plasma glucose, almost the same postprandial glucose value, also the same mean glucose value, but completely different glucose swings. Is it a new kid on the block? You can see the first publications of glycemic variability were published much earlier than I was born, 1965. It was a long journey till today, and we still don't know is it so important. But there is no doubt that in type 1 and in type 2 diabetes patients is found significant glycemic variability. Type 1 patients with type 1 diabetes are 2 hours per day in hypoglycemia and 7 hours per day in hyperglycemia. Patients with type 2 diabetes are 1 hour per day in hypoglycemia and almost 7 hours hyperglycemic. Riso and collaborators several years ago found that intermittent hyperglycemia enhances apoptosis in human umbilical vein, endothelial cells in culture, even more than continuous hyperglycemia. It seems that it's better for our patients to be hyperglycemic all the time instead of having different glucose swings. But also there are several other collaborators and several other studies. Cell culture study by Seriello showed increased inflammatory activation with glucose variability. On the other hand, studies of Monnier showed increased oxidative stress with increased MAGE. It seems that glucose variability could be the third or fourth measure of glycemic control. A few years ago, it was published excellent article about glycemic variability. It was wrote and it was published by people who were not physicians. They were just engineers, and they were in their review they were writing about examination of physical or glycemic variability and also technical components of that. And when we talk about glycemic variability, we can measure by CGM system, and we can control by MAGE, and also we can express glycemic variability by standard deviation. There are many other measures of glycemic variability. Today I will not speak about all of them because it wouldn't be enough 20 or 30 minutes. It will be much more. I would need much more time. But the most common measures of glycemic variability are standard deviation and also MAGE. Standard deviation is the most simple measurement of glycemic variability from self-monitoring blood glucose. It can determine both overall and type-specific standard deviation, but it needs at least 5, but prefer 7 to 10 determination per day. On the other hand, we have MAGE, or mean amplitude of glucose excursion. For that measure, we need continuous glucose monitoring system, and this is MAGE, the mean amplitude of glucose excursion during the day. It seems that not all technology helps diabetes. Like in this case, it seems that CGM can contribute to glucose control. Glucose fluctuation, there is some positive correlation and some evidence that oxidative stress in patients with type 2 diabetes are in correlation with glucose variability. It was found in type 2 diabetic patients. Unfortunately, it was not found in type 1 diabetes. Oxidative stress in type 2 diabetes is not related to HbA₁c, fasting glucose, fasting insulin, but also it's correlated with mean amplitude of glucose excursion. As I already explained you, in type 1, there is no evidence that MAGE is correlated with oxidative stress. Glycemic variability is a strong independent predictor of mortality in critical ill patients, in non-diabetic ICU patients, as you can see here. On the other hand, fasting plasma glucose variability is a strong and useful marker of nocturnal hyperglycemia, which can be helpful for our patients with frequent hyperglycemia. Which factor can influence on glycemic variability in diabetic patients? Deficiency in insulin and amylin secretion. On the other hand, lack of glucagon suppression after eating, and inappropriate use of insulin, but also poor compliance with diet and exercise. However, there are several controversial issues on glycemic variability. It seems that it's still not clear wherever patients with a very variable glucose profile during the day is at any different risk of these problems than someone without, with more stable glycemia. Glucose variability could have the impact and the role in the prediction of severe hyperglycemia. On the other hand, as you can see here, glucose variability is strongly related to oxidative stress. There is no doubt. But in vitro, animal, and human studies. But in real life, human studies were not consistent to demonstrate a relationship between short-term glucose variability and oxidative stress or macrovascular complications. Unfortunately, blood glucose variability cannot be predicted by HbA₁c. On the other hand, H2D reanalysis of H2D trial showed that lower intraday glucose variability did not result in reduction of cardiovascular outcomes. We can confirm that glycemic instability is an estimated problem in type 2 diabetes. And recent trials suggested that glycemic variability may be an HbA₁c independent risk factor for macrovascular complications. Activation of oxidative stress by hyperglycemia may play a major role in pathogenesis of diabetic complications, and that's the reason why we should minimize glycemic variability, what can be important aspect of glucose measurements. But unfortunately, for better measurement of glycemic variability, we have to have improved assessment of glycemic variability, what can help to reduce the risk of harmful hyperglycemia, and also can decrease the risk of diabetic complications, and can improve glycemic control as well. For that, we need improved diagnostic tools, maybe better or more affordable CGM system, and also individualized monitoring strategies, and we need more randomized clinical trials. I'm almost finishing my lecture, but when we are talking about glycemic variability, unfortunately, we can only confirm that glycemic variability is in positive correlation with oxidative stress and also markers of inflammation. We cannot confirm that glycemic variability is directly related to mortality, to hospital admissions, to costs, especially because the sensors for CGMS are very expensive and are not available in every single country. Future progressive trials evaluating and comparing the effect of the control of glycemic instability on the development of diabetic macro and microvascular complications are needed to further strengthen the evidence base, because we need to have a better protection for our patients. And at the end, I would like to send you greetings from my beautiful country, Croatia, which is the home of necktie. As you can see here, Croatia is a small country in the middle of Europe, close to Italy. We have coastal part of Croatia, and also we have inner part of Croatia. Since July the 1st, 2013, we became a member of EU. We have 1,185 islands, with one special island in the shape of the heart. We are proud on our history, on our historical buildings. This is our capital of Zagreb. But also we are proud on our historical buildings on our seaside coast. We have beautiful seaside coast, and I'm inviting you to visit us, with many historical buildings, many nice beaches, with a famous city of Dubrovnik, which is a historical place and one of the most famous destinations within Europe. There are some similarities between our two countries. Both countries are very beautiful. My country, the total population of my country is 4.2 million. The population of Chennai is even more, 4.6 million. But we have beautiful and special our national symbol, which is necktie or cravat, which is from the name of Croatia. And many gentlemen in this room are wearing that necktie. And also you can see in this room some people who looks familiar to you. We have beautiful beaches in your India and in my Croatia. But all together we have to fight against diabetes. We have to use all our weapons to try to prevent complications, to try to prevent hypoglycemia. And thinking about glycemic variability, especially in the matter of preventing hypoglycemia, could be very useful, because what we would like to achieve is long life for our patients with no complications. Thank you very much.